Knowing when ceritinib is not working anymore can be challenging. Often you can have patients who are feeling well, doing well, but their scans show there's been growth or there's a new lesion. This is actually a challenge not just limited to the ALK setting. This happens in other targeted populations like EGFR or BRAF. And even with our more traditional therapies like chemotherapy and now with immunotherapy, knowing when you should stop a drug is not always easy. In general, when somebody has florid progression on imaging and that correlates with clinical decline, it's a pretty easy thing to sort out. The most complicated scenario is somebody's doing really well physically, clinically, they feel well, they're doing well, but they have a new lesion in the brain. What do you do then? Often we will keep the systemic therapy going, ceritinib in this example, and address the brain lesions if they're symptomatic with something like radiation therapy. Radiation to that limited spot or spots can be an effective strategy. When you have a lot of new lesions though and somebody's feeling well, it's hard to keep that therapy going. So for example, multiple new liver lesions, new lung lesions, new brain lesions, even in somebody feeling very well, is the time to make a change in care, in my view. That's not a patient that's just going to stay well forever. That's a patient that in time is going to start to feel the effects of that progressive disease. And so making a decision whether to go on to a next generation ALK inhibitor as part of a clinical trial or moving on to chemotherapy is something that needs to be decided relatively quickly to make the best treatment plan for the patient. Following patients on oral therapy for ALK-rearranged lung cancer is very much like you'd follow anybody on treatment for any cancer. This is one area, though, that there's a couple of caveats worth mentioning. So one is brain imaging. So in addition to standard body imaging and physical exams and evaluating patients in your clinic, imaging the brain periodically is a must, in my opinion. And we don't, our third-party payers and guidelines don't always endorse that, but this is a common area for progression is the brain. And adequate studies, so contrasted imaging, ideally MRIs, are the best way to identify that. But if you're not doing it, then you'll never know. And a lot of times patients will miss the opportunity to have isolated lesions addressed with radiation therapy, and then it only gets discovered when they have florid, widespread progression. The other caveat I'll mention, and this is a relatively new thing, is blood-based testing is available, and there's some physicians who are asking or wondering, can they do serial monitoring or blood testing to try to identify progression earlier than maybe a scan will show. I guess simply said, the answer would be no, that we're not quite there. I think we can get there where you can use blood-based testing to help you understand, are you losing that control? Are you developing a resistant mutation? And I think there's value there. But right now, I don't think that's there in terms of routine clinical practice. I just don't know how far away we are from that being standard of care. It's just not quite there yet. When you're on a good drug like crizotinib or ceritinib or alectinib, you're really wanting to stretch that out as long as you can, but when it's time to make a change, you need to make that change. So when you have clear evidence of progression, again, these are scenarios where patients have obvious growth on their scans or new lesions in the brain, for example, that are symptomatic. This is the time to begin thinking about making a change in care. Ideally, it's a clinical trial, and ideally, it's getting access to a next-generation ALK inhibitor. Sometimes you can even identify the resistant mutation and steer your care to an agent that addresses that mutation. And sometimes it just means moving on to chemotherapy. A lot of these patients have never received chemotherapy. The oral agent has been their first and only therapy. And so you still have the benefits of platinum doublet chemotherapy. And for a lot of patients, that'll be carboplatin pemetrexed-based treatment. That'll be the regimen they move on to next. My only, little tip when a patient moves on in that transition is that it happened relatively quickly. Sometimes that gap between stopping their oral agent and deciding what to do next can lead to rapid progression of the cancer and clinical decline. So bridging the patient from their oral therapy to chemotherapy as quickly as possible is really the ideal strategy.